want to thank you all for your patience. We will now welcome our second panel of witnesses. Professor Judith Fader is a professor of public policy at the McCourt School of Public Policy at Georgetown University and a fellow with the Urban Institute. Mr. Edmund Heisley-Meyer, I do that every time, welcome back, is a senior research fellow for health policy studies at the Heritage Foundation. And Dr. Avik Roy, MD, is a senior fellow at the Manhattan Institute for Policy Research. As you saw in the first panel, pursuant to the rules of the committee, would you please rise, raise your right hands to take the oath. Do you solemnly swear or affirm that the testimony you're about to give will be the truth, the whole truth, and nothing but the truth? Please be seated. Let the record reflect all witnesses answered in the affirmative. Dr. Roy.
Chairman Issa, Ranking Member Cummings, and members of the Oversight Committee, thanks for inviting me to speak with you today about the Affordable Care Act. My name is Avik Roy. I'm a senior fellow at the Manhattan Institute for Policy Research, in which capacity I conduct research on healthcare and entitlement reform. I'm an advocate of market-based universal coverage. I believe that the wealthiest country in the world can and should strive to protect every American from financial ruin due to injury or illness. Furthermore, I believe that well-designed, subsidized insurance marketplaces are among the most attractive vehicles for achieving these goals. It is for these reasons that I am deeply concerned about the way the ACA's insurance exchanges have been designed and implemented. Most of all, I'm concerned that the law will drive up the cost of health insurance, especially for people who shop for coverage on their own. As you know, the ACA makes substantial changes to the individual health insurance market. The law broadly bars insurers from charging different rates to the sick and the healthy, and requires insurers to raise rates on younger individuals in order to partially subsidize care for the old. It mandates that insurers cover a broad range of services that individuals might not otherwise choose to purchase. The law taxes premiums, pharmaceuticals, and medical devices in a manner that has the net effect of increasing the cost of insurance. Earlier this fall, I and two colleagues from the Manhattan Institute completed the most comprehensive study to date of individual market premiums in 2014 relative to 2013. We examined the 5 least expensive plans available in the individual market for every county in the United States, averaged their premiums, and adjusted the result to take into account those who, due to pre-existing conditions, could not purchase insurance at those rates. We examined premiums for 27, 40, and 64-year-old men and women. We then compared those rates to the 5 cheapest plans on the ACA exchanges, an apples-to-apples comparison. Our analysis found that the average state will see a 41% increase in underlying premiums prior to the impact of subsidies. Among the states seeing large increases are Nevada, 179%, New Mexico, 142%, North Carolina, 136%, Vermont, 117%, and Georgia, 92%. Our analysis did find that 8 states will see average premiums decrease under the law, including Massachusetts at negative 20%, Ohio, negative 21%, and New York, negative 40%. Of the 6 categories we studied, 27-year-old men faced the steepest increases with an average hike of 77%. 40-year-old women will see the mildest increases with an average of 18%. We also studied the impact of the law's premium assistance payments on exchange premiums. Our analysis found that for individuals of average income, taxpayer-funded insurance subsidies primarily flow to those nearing retirement. This is because the elderly will still pay more for insurance on average than younger individuals, and because the subsidies are designed to fix the percentage of one's income devoted to paying health insurance premiums. Taking subsidies into account, 64-year-old men will pay on average 19% less for insurance under the ACA system, whereas 27-year-old men will pay 41% more. The Manhattan Institute analysis indicates that we are indeed likely to see a fair amount of adverse selection on the exchanges. People who consume an above average amount of healthcare services, such as sicker and older individuals, have a compelling economic incentive to enroll on the ACA marketplaces. Healthier and younger individuals, however, have less of an incentive, even when one takes into account the individual mandate. Our analysis did not directly examine the degree to which exchange-based plans have higher deductibles and narrower provider networks relative to plans available in 2013. There have been, however, many anecdotal reports of people paying higher premiums for plans with higher deductibles and narrower physician networks than the plans they previously enjoyed. In particular, prestigious academic medical centers that specialize in the most complex cases and the rarest diseases tend to provide costlier care than the typical American hospital. These facilities have been mostly excluded from exchange-based provider networks. It is not inherently a bad thing for individuals to choose plans with higher deductibles and narrower networks, especially if those choices allow Americans to reduce their monthly premiums. In theory, by encouraging price competition among healthcare providers, exchanges could exert a downward pressure on overall health costs. The problem is that in the case of the ACA, many individuals are reporting higher premiums for less attractive health coverage in a way that will, all in all, increase national health spending. It would be one thing if the ACA was forcing Americans off their old plans and offering them more attractive plans at a lower price, but millions of Americans are likely to see less attractive coverage at a higher price. If they do, then the Affordable Care Act will not live up to its name, and its goal of near universal coverage will remain unfulfilled. Thank you.
Thank you. Ms. Fader.
Chairman Issa, Ranking Member Cummings, and members of the committee, I welcome the opportunity to speak with you today about the Affordable Care Act. My views are my own, not those of Georgetown University or the Urban Institute, where I've spent much of my career. And over my career there and elsewhere, I, like you, have watched the number of Americans without health insurance rise to 50 million people and go without care, even as Americans who have health insurance spend more and more to hold on to it. At long last, the Affordable Care Act enables us to assure Americans access to affordable health care. We have a simple choice: effectively implement the law or resign ourselves to the unacceptable status quo. A status quo that I believe is quite different, the evidence tells us, from the rosy picture that we were left with in the last panel, where everybody gets their care and their doctor and all is well. My own research has contributed to a substantial body of literature demonstrating that insurance matters. Americans without health insurance get less care, get it later in the course of an illness, and are more likely to die than Americans without it. And to the extent they get care, that care is paid for by those of us who have health insurance in our insurance premiums and through our local, state, and federal taxes. Who are the uninsured? They are mostly workers or families of workers who are not offered coverage through their jobs the way most of us are. Pre-ACA, they have few options to protect themselves. Coverage in the non-group or individual market, with denials of coverage for pre-existing conditions and limited benefits and rescissions and non-renewals, simply does not work for people when they get sick. Far from living up to the promise that people who have this insurance can keep their doctor or their doctor is paid for, Mr. Chairman, as I heard you argue, the limits on their annual payments as well as other limitations frequently leave them high and dry, and that is what the evidence tells us. And though Medicaid provides an invaluable safety net for people who are eligible, it is far from an empty card or an empty promise, and research shows us it actually does get people access to care. Except in a few states with waivers from federal law, Medicaid excludes coverage of adults who are not parents of dependent children, no matter how poor they are. So the very same low and modest earners who can't get coverage through their jobs can't get public protection. It is these giant holes in our health financing structure that the ACA aims to fill. As Avik said, the ACA requires insurance to end discrimination based on pre-existing condition, gender, and other factors, to cover the range of services health professionals typically provide, and to eliminate dollar caps on annual and lifetime benefits. And so that people don't wait until they get sick to enroll, the ACA accompanies these requirements on insurers with requirements on individuals to purchase coverage or pay a penalty. And to make that requirement feasible and coverage affordable, the ACA provides tax credits and other protection to limit people's premiums and cost sharing as a share of income. These policies together make it possible to transform what is an empty card in the individual market today into what insurance is is supposed to be: available, adequate, and affordable. And the ACA addresses the holes in Medicaid by expanding its eligibility to people with incomes below 138% of the poverty level, regardless of their family status. Until 2017, that expansion is fully financed by the federal government, with federal financing gradually dropping to 90% for 2020 and subsequent years. Although states will ultimately pay 10%, analysis shows that the expansion will make states financially better off by reducing the burden of uncompensated care while contributing to the overall health of state economies. Indeed, research shows that because taxpayers in all states contribute to financing for the ACA, citizens in states that choose not to participate in Medicaid will actually pay for benefits in other states without reaping any of the benefits for themselves in additional federal funds. Now, while the ACA expanded coverage by improving the market outside employment, it is important to emphasize that the law leaves the employer-sponsored insurance that most of us depend on fundamentally as it is today. Despite claims to the contrary, the analyses by CBO, RAND, and my colleagues at the Urban Institute show that employer-sponsored health insurance will remain the core of the American health insurance system. Essentially, we've left roughly 150 million people who rely on employer-sponsored insurance. Their coverage is the same as it's been, not with some improvements, and they are not affected. They were not the group that we were talking about this morning. That is the coverage outside of employment. At the same time, well, I see my time going, we have seen the slowest cost growth that we've seen in history, in part a function of the ACA's elimination of overpayments to Medicare and promotion of initiatives to support efficient, higher quality care. And that is affecting everyone. By filling the gaps in our current financing structure and slowing the growth in our healthcare costs, the ACA has enormous potential to address the flaws in our healthcare system that all of us decry. The biggest barrier I see to realizing the law's potential is the political resistance to its implementation, with too many states unwilling to establish their own marketplaces or to expand Medicaid, despite the enormous advantage to their own citizens. Come January 1st, millions of Americans will, for the first time, have access to affordable insurance they can count on when they're sick, along with the benefits people are already reaping from the ACA.
The gentlelady's entire statement will be placed on the record. We now go to the gentleman.
May I finish the sentence? I thought you said earlier that everybody got to finish their sentences.
You may finish the sentence, but not the entire script.
That's
Your
just
1 minute passed, and you did say you were wrapping up.
And
so if the gentlelady will finish the sentence.
I'd be glad to. Along with the benefits that we see people already reaping, we need to move forward to implement the real promise of the ACA. Standing in its way and standing for the unacceptable status quo is simply wrong.
Thank the gentlelady. We now go to the next witness, Mr. Heisley-Meyer.
Thank you, Mr. Chairman, Ranking Member Cummings, for inviting me to testify today. I'm focused my testimony on the issue the committee asked to talk about of limited provider networks in the exchange plans under the Patient Protection Affordable Care Act. You have a copy of my written testimony. I'll simply summarize a few of the points. Obviously, as you've heard in the panel before, provider contracting is nothing new. It is a two-way street. It is up to both the insurers and the providers to come to terms. If one of them doesn't like the terms, you don't have a contract. That shouldn't surprise anyone. Is there something significant or different about the contracting and the networks in plans in the health insurance exchanges under the Patient Protection Affordable Care Act? There appears to be, based on the widespread news reports, and by that I mean from all sectors of the country and involving all different types of providers. With that said, nobody has at this point any definitive conclusive handle on the extent to which those provider networks are different from the ones that we see out there today. We just simply don't know, in part because some of those networks are still being built. Those contracts negotiations are still ongoing. What we do know, though, is that in a number of cases, the insurers are offering network coverage that is significantly less than what they offer in plans outside of the exchanges. The thing I would direct the committee's attention to as a policy matter is that what I see driving at least some of this, because the assumption has been that, well, the consumers will be price sensitive and the insurers are trying to keep prices down, so they exclude providers. But I think the design of a portion of the law actually drives this. I'm specifically referring to the cost-sharing subsidies. Most of the attention has focused on premium subsidies, but the law has a second set of cost-sharing subsidies that pays the insurer to reduce the cost-sharing for lower-income enrollees. The problem with that is that because the cost sharing for a significant portion of their expected enrollees is nominal, the insurers have reason to expect that there will be higher utilization, and indeed HHS confirms that. HHS is adjusting the cost sharing subsidies to reflect their estimate of higher utilization. Essentially what's happening is insurers will get paid, but they are no longer able to use a tool of cost sharing to steer patients to be more prudent consumers. Thus, they must rely on other tools, and that's, I think, one of the reasons we're seeing narrower networks in these plans. The other interesting thing that I found in research that I did and was published at the beginning of the month, and I think I'm the only one who's done this so far, is I analyzed all of the insurers who are participating in the exchanges and looked at them and their businesses in the state today, and sort of the insurers that are not as well, and to see what kind of patterns emerge. One of the interesting patterns that has emerged from that is 20% of the carriers who have gone into the exchange, their principal business in the state where they went into the exchange is Medicaid managed care. And indeed, we do find evidence that these plans recognize a structure, meaning the patient faces very low premiums and only nominal cost sharing for a generous benefit package that looks a lot like what they're dealing with in Medicaid managed care. And indeed, I quote one of the CEOs of those plans saying, yeah, it looks essentially the same, that's why we went in. Given that, my expectation of how this plays out is that individuals at the lower end of the 100 to 400% of poverty that will be subsidized, 100 to 200%, will probably gravitate towards the silver plan, particularly if you've been uninsured. The trade-off of low premiums and low cost sharing for limited provider access is not necessarily something that you're going to be terribly upset about, especially if you're coming from not having insurance. However, somebody who is used to having insurance, who makes more money, who's maybe 300 to 400% of poverty, paying higher deductibles and co-pays for a limited provider network is not going to be attractive. And so I expect those individuals would probably move to bronze plans, or if certainly above 300% of poverty, the subsidies are quite small, they might just look for coverage elsewhere. So I think that is going to be the dynamic that plays out. At this point, it remains to be seen how many of these more limited networks we see in the coming days, but I expect that will probably be fairly prevalent. My time is about to expire, Mr. Chairman, so thank you again and be happy to answer questions.
Thank you. I now ask unanimous consent that an article in Bloomberg in September of this year be placed in the record. It is entitled, "Recession Not Health Law May Be Responsible for Cost Curbs." Without objection, so ordered. Dr. Roy, you mentioned free market as a better way to get a working system. And earlier on the first panel, I asked all three doctors about the practice that the Federal Government in its reimbursement pays different rates for the identical treatment depending upon where you have it. Isn't that an example of an inherently flawed system, in that if a hip replacement done in a clinic that specializes in it does therapeutically an equally good or better job with equal or better results, and does it for a more efficient way, and whatever that term means, less overhead generally, that by paying them less and paying a hospital more, you're essentially driving up the cost of health care by subsidizing hospitals even if they have higher overhead. Isn't that correct?
It is, and it's a distortion that Medicare introduced into the market and has been around and has gotten worse over time as Congress tries to tweak that problem and make it better. Sometimes there are unintended consequences that make it worse as well.
In my own state of California, we're seeing hospitals buying up clinics and physician practices at a high rate, paying them essentially as much as more than their practice is really worth, not because they're generous to the doctors, but because the anticipated revenue growth means that the same doctor doing the same job in the same facility, once they become part of a hospital, pays more. Therefore, the hospital is doing this in order to increase its revenue. Is that something that, in a small way, we should be attacking as part of our reform?
We should, and in fact, I believe MedPAC has recommended modifying the reimbursement structures so that Part B and Part A pay the same rate in that instance so that this arbitrage can't continue. And I would also mention that hospital consolidation broadly, provider consolidation broadly, something that the ACA actually accelerates, is a serious problem which is driving up market power for these providers and driving up prices in the commercial market.
One last question, and I think for a couple of witnesses. In 1960, we spent 5% of GDP, then smaller GDP, on health care, and we lived about 7.5 years less long than we do today. Today, we're spending roughly 18% of GDP. That's not just almost 4 times the amount, but actually with GDP growth in constant dollars, we spend about 5 times as much on health care as we spent then. I'll start with you, Doctor. As a physician, is there a real justification, in spite of all the improvements, is there a real justification for spending 5 times as much in real dollars on health care, or have we essentially built inefficiencies into the system, and if so, does the Affordable Care Act attack any of those inefficiencies?
The Affordable Care Act increases the amount that we're going to spend on health care, unfortunately, and I do agree that it would be nice to spend less. We don't need to spend as much. There's enormous amounts of inefficiency and waste in the way we deliver and pay for health care, and these are long-standing problems which some things about the Affordable Care Act may address, we hope, but broadly speaking, it goes in the other direction.
Mr. Heisley-Meyer, there's a couple of questions. First of all, you were at the table at Heritage during the Affordable Care Act markup, were you not?
Well, I was at the Heritage Foundation, yes.
Right, but
I mean, I wasn't participating in the markup.
No, well, trust me, I wasn't at the table either, in spite of what Mr. Tierney said. But when you watched that process, were there any ideas that came out of Heritage that, or other, if you will, conservative Republican groups that you saw being accepted as amendments from any source? And particularly, I want to talk about medical malpractice reform such as MICRA.
Yeah, no, I mean, well, on medical malpractice, actually, we had somewhat of a different opinion than some of our friends in Congress who wanted a federal solution. We thought it should remain at the states. But that said,
I'm just saying, the Affordable Care Act barred it for the states from doing it.
My observation is that, frankly, the bipartisanship ended right about, and I could look up the exact date, it was July of 2009. It was the day they finished the Help Committee markup in the Senate. And in that markup, the Republicans had made a number of substantive changes, all of which were voted down on a party line vote, and then proposed a lot of technical changes to which, in my opinion, was the worst drafted of all the bills that were considered. And they accepted like 100 of those and then announced they had a bipartisan bill. And I think at that point is when the Republicans walked away, because I had been working with members and you know, there were things that they were drafting to submit that at that point they just didn't submit them. It was clear that there was not going to be any meaningful input. So, you know, the interest in sort of doing something bipartisan pretty much stopped right about mid-July, from what I could tell, because the demands for me to help people draft things just evaporated.
Thank you. Mr. Cummings.
Yeah, Dr. Feder, according to Doctors for America, some states, and I quote, have much stronger requirements for general providers and also for essential community providers. Some of these stronger state requirements include the following. And the reason I'm going to this is because the people on the panel before basically blame the Affordable Care Act for the reason why they may not be on a provider network. But these are some state guidelines, the reasons why the requirements. Provider covered person ratios by specialty or primary care, geographic accessibility, waiting times for appointments with participating providers, hours of operation, volume of technological and specialty services available to serve the needs of covered people who require advanced or specialty care. Dr. Fetter, so if there are concerns within a state about the adequacy of provider networks, who can consumers go to and what actions can states take to address those concerns?
Well, actually, Mr. Cummings, you are rightly raising that the Affordable Care Act actually establishes requirements or calls for requirements for network adequacy. And as in many areas of the law, it leaves it to the state to enforce those requirements, and I think we need attention to them. It's a legitimate requirement. It does fall to the insurance commissioner in the state, and states have different degrees of willingness and ability to address it, and we're not seeing an active enough effort in that regard, and we need to attend to it.
Now, you have decades of experience in assessing, Dr. Fetter, the healthcare system, and we hope to have you on the first panel, but here you are. Dr. Fetter, one of the most critical features of the Affordable Care Act is its expansion of Medicaid eligibility to millions of low-income adults. Prior to the ACA, Medicaid eligibility was restricted primarily to low-income children, their parents, people with disabilities, and seniors. In most states, adults without dependent children were not eligible. According to a study issued on October 23rd by Kaiser Family Foundation, only about 30% of poor, non-elderly adults had Medicaid coverage in 2012. Under the ACA, Medicaid eligibility can be expanded to cover all non-elderly adults with incomes below 138% of the federal poverty level. The federal government would pay the states 100% of the cost for the first 3 years and then phase down its match to about 90% by 2020. Is that right?
It is correct, Mr.
Now, despite this huge level of federal assistance, as many as 25 states have decided not to be a part of the expansion, leaving millions, literally millions, of their own citizens without health care. Is that right?
That's absolutely true.
Now, Dr. Fetter, what is your opinion of states that refuse to expand their Medicaid programs?
My opinion of the states, I am sad and disappointed for their citizens, both the citizens who need care and the citizens who are contributing to paying for care through their taxes in other states that do expand. The expansion, research shows from the Commonwealth Fund, the Urban Institute, RAND, how much in the interest of states this expansion is, and I believe it is only political opposition to this law that is depriving these citizens of access to care and the states of needed revenue.
So by not participating, aren't they leaving significant resources on the table that could be used for their citizens?
They sure are.
And sadly, a lot of these people are getting sick and sicker, and sadly, some of them will die early.
Well, we know that essentially the Institute of Medicine found that lack of insurance kills, and so your statement is correct.
Why is the expansion of Medicaid an important component of the Affordable Care Act? Why is that so important?
Well, we've had a big hole, as you point out, in our safety net coverage, our floor of protection, and that is that if you are not the parent of a dependent child or disabled or old, you really are not, or a child, you are not eligible for coverage in most states. That hole is a vestige of an old-fashioned welfare system that kind of assumed that these people would get coverage through their jobs. They don't get coverage through their jobs. They are left out of employer-sponsored coverage, and they're left out of the public safety net, and that's why we need to expand it.
Now, the Commonwealth Fund issued a study this month showing that states that expand Medicaid will gain important benefits beyond covering the poor people, such as reducing uncompensated claims. Tell me something. I remember reading something about Missouri, and a lot of the hospital administrators came and said to the governor, you've got to accept this because our hospitals are going to be in trouble if we don't accept provide for Medicaid expansion. Can you explain that to us?
Sure. That is, hospitals, although they don't provide unlimited care and people without insurance don't get all they need, hospitals get stuck dealing with people who don't have insurance coverage. They have to provide emergency care. Doesn't mean everything, but they're stuck and they don't get paid.
Yeah.
What this law created was the opportunity they get paid for patients who walk in the door, and they're counting on it.
Just one last question, Mr. Chairman. The same study says that by choosing not to expand Medicaid, some states will lose billions of dollars, and I quote, and I talked to Senator Cruz about this the other day. Texas, for example, will forego an estimated $9.58 billion in federal funding in 2022. Taking into account federal taxes paid by Texas residents, the net cost to taxpayers in the state in 2022 will be more than $9.2 billion. Similarly, Florida's decision not to participate will cost its taxpayers more than $5 billion in 2022. And Georgia, I could go on. Dr. Fetter, what will this mean with regard to sick people in those states?
Well,
by the way, in Texas, 1 out of every 4 person has no insurance.
That's where most of our uninsurance is, and it's going to stay there. And those people are left without access to care, and as you said, they are more likely to suffer and more likely to die as a result.
Thank you very much. Thank you, Mr. Chairman.
Thank the gentleman. Dr. Fetter, are you a physician?
No, sir.
Is Medicaid financially sustainable?
Medicaid,
Yes or no? Yes or no? It's an easy one.
You know,
yes
no,
or no?
it's not actually an easy one.
It is really easy.
No, it isn't. You know, because it's about long-term care in large part,
No.
which is what Medicaid costs are growing very slowly. We got too many low-income people in this country.
Based on reimbursement rates, it's unsustainable. Would you
No,
agree with that?
not the reimbursement.
Doctor?
I thought you were talking about
It's financially unsustainable.
I
the way it is.
I don't agree.
Dr. Roy, would you agree with that?
It's unsustainable. I should just add, I'm not a physician, though I did go to medical school.
Yeah. Mr. Heisley-Meyer, is Medicaid sustainable financially?
No.
Not in the present form. Even expanding, it's not either, is it?
No, that would.
Put on your mic.
Put your mic.
I'm sorry, I hit the wrong button. I hit the button the wrong time. No, it's not sustainable in its present form, and with the expansion, we'll simply add to that in a number of ways. It could be if you reformed it along different lines, but that's a different subject for a different day.
So, Dr. Roy, you heard the comments that we saw Ms. Federer just talk about. What's your opinion in regards to, are we not just chasing our tail with the expansion of Medicaid?
So I recently published a book entitled How Medicaid Fails the Poor, and it details in 48 pages how the reimbursement structure of the program, how it underpays physicians for care, has led to very poor access for those individuals, and that's leading to poor health outcomes. So the most definitive study on the score was conducted in the state of Oregon. It was published in the New England Journal of Medicine by a panel of esteemed health economists, which showed that Medicaid, compared to being uninsured, showed no improvement in health outcomes.
So because you get a card, does it mean something that when you have a card, if you don't have providers to see you?
You heard in the earlier panel this morning, just having a card that says you have health insurance is not the same thing as access to care, and that's a distinction that I fear that the Affordable Care Act has not understood well.
So when we're reimbursing physicians below market rates, work for them to even make a profit. We just heard the gentlewoman basically make the comment that it's up to the states to enforce proper panels. So we're going to force physicians to take fees that they can't even pay their own bills?
In Massachusetts, under the most recent health reform bill they passed in 2012, they considered a provision that would have required all licensed physicians in the state to accept all forms of payment. The physicians rebelled, and that was not included in the law. But that is something that we may see more of over time, an effort to do that, and that would be problematic.
So let me ask you the next question. So you're very familiar with debt coming out of school. Are physicians coming out of school less debt or more debt?
More debt. Unfortunately, the cost of medical school has skyrocketed. It's increased perhaps more than health inflation.
So reducing their fees is going to help them better pay that?
It has discouraged a lot of new physicians from accepting Medicaid patients. And again, today, all the surveys and studies show that the percentage of physicians who are willing to accept new Medicaid patients is substantially lower than it is for private insurance in particular and Medicare, though that's also increasingly a problem. Over time, as states expand their Medicaid programs, they will face further fiscal pressures. The only real mechanism that states have to keep their budgets under control under Medicaid is to turn down the amount they pay physicians and hospitals to care for these patients. So this problem is only going to get worse over time, and the Medicaid expansion will accelerate that.
And so more of it, we heard earlier in the panel, the earlier panel talking about patient dumping. So this is like federal patient dumping onto states for that jurisdiction. Do you not agree?
In my experience, physicians who are already caring for a patient are really reluctant to let that patient go just out of a humanitarian interest, but they're very reluctant to take on new patients, to commit to new patients under that reimbursement structure.
Because it puts them in a harmful situation, does it not? Because they can't abandon a patient because that's a litigation type of point. There's very ethical problems here.
Yeah.
So understanding urban and rural dictations, we are really skewing the benefits for rural. I'm from rural Arizona, and we are seeing huge catastrophic access issues. I mean, in the previous administration, we tried to look at federally qualified health centers, which the gentlelady didn't bring up because they're not to turn away anybody. It's a sliding fee scale, if I'm not mistaken, right?
Yes.
Yeah, I mean, they can't turn anybody away. So, I mean, that was part of the safety net. Yeah. Unfortunately, I practiced kitty corner for one. I saw the patients they didn't want to see because they skewed the results. What they did is they took Medicaid and Medicare patients and skewed them to a 1% of the day, and they took fee-for-service patients and insurance patients, and they took them at a regularly scheduled appointment. Very skewed results.
One thing we should point out is that what the market price would really be in a free market system for paying doctors and hospitals, we don't know because we don't have a free market for healthcare, because Medicare in particular and also Medicaid have so distorted what the prices are for a lot of services. And the evidence suggests that in general the prices for these services in the United States are higher than they are in other countries.
And I'm going to take the liberty, since I gave the gentleman a little extra time. And that's one of the reasons why we don't have a lot of family care physicians. Isn't that true? Is that government has skewed that process and reimbursement rate so that everybody goes into the specialty because that's all you can make a living.
What you'll hear every physician say is they get paid for procedures, for writing prescriptions. They're not paid for their time. And that's what a lot of physicians like about so-called concierge or retainer practice. They're finally paid for their time and they can spend more time with their patients. Unfortunately, the evolution thereof may lead to a two-tiered system where you have the doctors treating Medicaid patients who don't spend a lot of time with those patients.
One last question. You know, we hear this downtick in expenditures for health care due to the ACA, and I don't agree with that. I think that had a lot to do with the economy. Would you agree?
Yes. In fact, I've written about this. So in general, across the OECD countries, the developed world, there's been a massive slowdown in the growth of health expenditures driven by the global economy. Also, there's been a substantial evolution in the United States, or an increase in the use of high deductible plans with health savings accounts in the employer market. That's also leading to a slowdown in spending.
I thank the gentleman.
Chairman, yield just for a second.
I would happily yield.
Why don't we want to give the president any credit? Any credit. I mean, I hear this over and over again. The cost of insurance is going down, and you're trying to say that President Obama and his efforts with the Affordable Care Act had no effect?
As you know, sir, the bulk of the Affordable Care Act has not been implemented yet, so it's very improbable that the Affordable Care Act is having a system-wide effect on health spending.
Yes, Ms. Fetter, and then
I think there are two challenges, Avik, and I think we agree a lot on the power of the recession and bringing costs down. But what is missing from that picture is that Medicare, that in the Affordable Care Act, by making Medicare a more efficient, effective payer in terms of the reductions in overpayments, and there may be room to go, but they've done that made a big difference to spending, and that the whole thrust of the Affordable Care Act on the cost containment side is to move to a more efficient delivery system in many of the ways that people on both sides of the aisle would like to see it move. That part has not had much effect yet, I would argue, although the administration does point to the reductions in readmission rates to hospitals as already showing an influence of those policies.
Mr. Heisley-Meyer, you were nodding. I would like to give you the opportunity.
Well,
This really gets to the core of the debate over health care. I mean, look, the chairman was talking about the percent of GDP. We all know that we as a country spend more per capita percent of GDP than any other country in the world on health care. We also are all pretty much across the political spectrum not satisfied with the results. It's uneven, too many uninsured, et cetera. So I do this in my general audience talks. I make the observation that what we have here is a value problem. The value is the relationship between what we're spending and what we're getting. I don't care whether you're buying a hamburger or you're buying health care. And we're either paying too much for what we're getting or we're not getting enough for what we're paying. So the central challenge in health care is how do you improve value in the system? Ideally, what you would like to do is to get more and pay less. I think we would all agree on that. I don't think there's any disagreement on that. The problem comes in on how are you going to do it? And as my colleague just pointed out, there is a viewpoint that she holds and is embodied in this legislation that we can do this by having better micromanagement of doctors and hospitals and insurers and all the rest. The other view that I hold and my other colleague holds is that the way you do this is to have government limit itself to what it is competent at doing, which is pretty much in this case taking money from A and giving it to B and stay out of trying to run the rest of it. And if you want to give B a little more money than C, and that's fine too, but just move it to a patient-centered system where people can pick and choose and seek value and be rewarded for providing value. I look at the system, as do folks on the other side, and we all look and we say, well, gee, look at Mayo or Geisinger or Intermountain Health or Cleveland Clinic. They all provide better results at a lower price. And I look at the system and I say, okay, if that's true, why aren't they eating everybody else's lunch? Why aren't other hospitals having to come to their standards to go out of business? Thanks to my office, I have a BlackBerry, but they aren't so good. They're getting their lunch eaten by Apple. Okay, why isn't that happening in hospitals? Because we're propping them up with all these payments, et cetera. The other side looks at it and says, look, we can go into Mayo and study how they do it, and then we're going to write a bunch of rules to tell everybody else how to do it, and then we come out with the Affordable Care Act and the accountable care organizations. That's just a difference of how you go about doing it.
I hear you. Thank you. I now recognize the gentlelady from New Mexico, Ms. Lujan Grisham.
Thank you, Mr. Chairman, and I have to say I really appreciate the panels and this committee because I've been, I'm not a doctor, although I have a JD, and so Dr. Fader, thank you for your graduate work, and I will tell you, you're welcome, and I will tell you that I think that I can be qualified as a healthcare expert for three reasons. I'm a patient. Every single day, all the time, more than I want to be, try not to be, try to do everything right, doesn't matter. Two, I'm a primary caregiver for a chronically sick mother who is incredibly complicated, and I don't care what system you put her in. She's all by herself, she's navigating it, she's doing concierge, she's on Medicare, she's on Medicaid, she's on indigent care, she's on UNM care, she's on her own, she's married to a dentist. Doesn't matter. It's exhausting, complicated, so complex, I could spend the rest of my life explaining it to her, and she's a smart woman, gave birth to me. But can't do it. And I've done healthcare in policymaking for 30 years. So here's, for me, what's telling. You say that there's been an economic downturn, and that that's what you said, but the economy itself has played a huge role in the reduction of healthcare costs. CBO says exactly the opposite. We can work every single day and get experts from every single place to give us a different opinion. We have the most complicated, convoluted system in the world. And the Affordable Care Act at least tries to level that in many ways, but I'm one of those policymakers that think we need to go do a lot more, and I spent 20 years before the Affordable Care Act and before states were figuring out how to do Medicaid waivers and before we made changes to Medicare, and I watched HMOs and provider networks shift and change every time there was a profit motive to do that. Every single time. I dealt with patients who were left out, left under, left cold, no matter how much they were privately paying for their health care. Depends on who you are, where you live, what's going on. And what I mean by who you are more likely to be chronically sick or not? Are you living in an urban center or not? So we're going to have to do not one size fits all. We're going to have to do many sizes all the time, and this is a great experience about many people get better care as a result of the Affordable Care Act and get access. In New Mexico, we're paying some of the lowest rates in the country because of the Affordable Care Act. Our problem is going to be insurance regulatory oversight, and we don't have enough insurance companies. Never thought I would say that in my entire life. But it happens to be true in this case, regardless of what my personal opinions are. It is true in this case. So what I'm really interested in is using experts such as yourselves and others to start thinking about ways, because we just cost shift in this country. And what you're even proposing to some degree is more cost shifting. Cost shift back to the states. Cost shift back to the individuals. Cost shift back to business. Cost shift back to veterans. Cost shift, what do we have, 9, 10, 11 independent systems of care that no other country has with a not very robust public or community health system. Those are the real reasons that healthcare doesn't quite work in the way that we want it to. And I hope that all three of you stay dedicated, help us navigate those critical next steps, because I don't think that the Affordable Care Act is responsible for shifts and limited access. I think that it will exacerbate that in some cases. I don't think coverage means access. And I think that it'll improve it in some. And I hope that we're wise and brave enough here to continue to use experts such as yourselves. I never mean to do these diatribes, but there are no simple questions, and there are certainly no simple answers. There are not, except that if we don't start leveling the playing field, and we don't start really focusing on consumers, and we're not brave enough here to deal with the folks who are still have significant problems before the Affordable Care Act, with the Affordable Care Act, through the Affordable Care Act. I pay more because of the Affordable Care Act. But that's because I'm required to go to the DC exchange, not because I'm a consumer left to navigate through the Affordable Care Act rules in my own state. So it depends on the real details of those issues. So on the one hand, I can tell you that I'm one of those folks who's complaining, and on the other hand, I can tell you that I'm really glad that more people are helping me help you pay for my mother's chronic care procedures every single day, and I will tell you that she's more than happy to help pay for everybody's maternity care so that that all gets leveraged out, because I was also a county commissioner, because it's not just Medicaid. Medicaid's gaps are paid for by local government, which is paid for by taxpayers. It is all paid for by all of us every single day, all of the time. So I guess my question is, and Mr. Chairman, thank you so very much, is there a way that this committee can continue to work hard to get as much valid information about really what we can do starting today? Because my provider network's changed, because every time you do a reform, we open a window for somebody to legally do adverse selection and cherry picking, and that is not dealt with at the federal level at all. And if I was a for-profit insurance company, and it's legal, why would I create a network that has the sickest patients? Why would you do that? You cannot. So you don't. And that is not all of the reasons that occurs, but make no mistake, in my opinion, there's nobody here, not any panel, that can convince me that that's not part of the reason that it's always happened. So thanks for being here, Dr. Fader, and all the other doctors on the panel. Thank you for my diatribe. I feel great today, and I'm going to get my pins out of my finger, and I'm going to try not to be one of the expensive high-end users of healthcare, no matter what I pay. Thank you, Mr. Chairman.
I thank the young lady from New Mexico, and I'd hope that she would sign on to my bill on repealing McCarran-Ferguson after listening to you. Because, you know, one of the things that you have to look at is getting to the least common denominator, and I'll talk about that in a second. Gentlemen.
Thank you. Thank you, Mr. Chairman. I'll briefly close. I want to just go back very briefly to Dr. Roy, something you said, and I'm not asking any questions, I'm just giving a statement. On September 9, 2013, CBO Director Doug Elmendorf issued a paper entitled The Slowdown in Healthcare Spending. Drawing from multiple sources, the paper concluded that healthcare spending growth has slowed dramatically across the country. The slowdown in healthcare costs growth has been sufficiently broad and persistent to persuade us to make significant downward revisions to our projections of federal healthcare spending, he said. He goes on to say specifically, CBO found that relative to its 2010 baseline projections through 2020, Medicare spending is 15% lower than projected, Medicaid spending is 16% lower than projected. Now, this is the CBO now. And private health insurance premiums per enrollee are 9% lower than projected. He goes on to say, the paper also made clear, by the way, that these reductions, and listen to this, are apparently not because of the financial turmoil and recession, but because of other factors affecting, and this goes to what you said, Dr. Fetter, the behavior of beneficiaries and providers. And with that, I say this, witness in the prior panel said we got to get it right, we got to fix it. Chairman Issa, a few minutes ago, talking to one of our colleagues, Mr. Horsford from Nevada, said, you know, there are things that we've got to do to try to fix certain parts of this. And we have to. We have to get this done and get it done in a way where there's a win-win-win-win-win-win. And I do believe that that's possible. And again, I say that coming from having traveled some 20 hours on plane to go to Nelson Mandela's memorial, I got to tell you, I left there saying to myself, you know, we are so fortunate in this country. We are so fortunate to be where we are, and we can accomplish anything. We just got to put our minds to it. And someone once said, you know, it's not that people don't know what to do, it's whether they have the will to do it and do it. And so, again, I want to thank you all. Your testimony has been extremely helpful, and we're going to go forward.
Thank you.
I thank the gentleman. I'd like to ask the gentleman a question. Do you believe the actuaries for Centers for Medicaid and Medicare Services?
Give me the specific question, and then I'll try to.
Well, would you think that their spending, under oversight of spending, would be more deliberative and more accurate than CBO?
I'm not sure about, but one thing I do know.
And they deal with it every day. I mean, this is their due diligence. The actuarials deal with numbers. Would you?
Well, the fact is that, again, I quote what I just quoted. I do, again, the costs are coming down according to CBO. And, you know, and the reason why I got a little upset a few minutes ago, Mr. Chairman, and I appreciate your question, but it seems like this president gets no credit for anything. Nothing. Zilch. And over and over again, I mean, when everything goes well, oh, it must have been a mistake, must have been a fraud. If it goes bad, oh, it's his fault. The fact is that there's a lot that can come out of this. We've just got to have the will to get this done, and we'll get it done.
Well, I just want to go back to my question. The actuaries at the Centers of Medicare and Medicaid Services, who do not answer to the White House, said yesterday in the journal Health Affairs that the costs ease because of the economy, not because of Obamacare. Would you agree with that, Dr. Roy?
Yes, that's the overwhelming evidence, and I would just add that I'm an admirer of the president, and if the Affordable Care Act is successful in achieving its goals, its stated goals, I will be absolutely thrilled. My concern is that it will not, and I think it's my obligation to alert the committee to the concerns that I have.
Mr. Chairman, you asked me a question. I just want to answer it in fairness to you.
Yes.
Earlier this year, the Centers for, they also said this, the Centers for Medicaid and Medicare and Medicaid Services issued a report finding that national health spending had slowed to only 3.9% in the years between 2009 to 2011. This represents the lowest growth rate in health care spending since government began keeping these statistics in 1960. I mean.
Yeah, you know, being a dentist, just so that I'm fair about this, is I can tell you about that spending is because dentistry didn't sell its soul to the federal government for the most part, and there are problems. Don't get me wrong, but the problem is expendable money that you have at leisure, and we have seen it go down. There is nobody who has got flush with money in their pockets to buy increased care or to do invest in your health care. There is none. I personally am empowering patients. That's what Nelson Mandela would have wanted, is empowering patients, not to make them cripples, but to be the entrepreneurs and to hold on to their health care and demand that system benefit them. Patient-centered, patient-friendly has to start, and that's not what is included in before Obamacare or in Obamacare. It is a government-dictated centric relationship. I want to see the patient benefit and be empowered not to be a cripple. So I want to comment, thank the witnesses for coming forward. We appreciate it. And with that, we'll adjourn this meeting.